We're having our annual meeting now in Milan, which is going to cover a number of topics which are very important to clinicians and trying to understand and best treat older patients with cancer. We had a session just now on advances in medical oncology, which covered issues about immunotherapy and targeted treatment, as well as other issues regarding radiation oncology, surgical oncology, and how to best assess patients and issues about patient selection and evaluation. I think what's happening in the field of geriatric oncology in this session and the sessions we're going to have in the next 2 days really reflects this, is that geriatric oncology is now really mainstream oncology. You can't think of it as a separate field. This is not a niche field of a few dedicated investigators. This really is a field of all of medical oncology. I always like to say that all adult oncologists are geriatric oncologists. They just don't recognize that yet. But when they see their patients day in and day out and realize that the majority of patients that they're going to be seeing are over the age of 65 or 70, and the majority of cancer mortality and drug consumption is in these older patients, they have to understand that there's a realization that they're going to have to understand basic principles about taking care of older patients and evaluating older patients. They don't have to become geriatricians per se, but they have to understand some very simple geriatric principles which will help them to take care of their patients in an optimal fashion. Through the work of many investigators, there's now a number of predictive models that we could use to help clinicians make data-driven decisions. We don't have to rely solely on clinical judgment, which is helpful, but one of the interesting things is that these predictive models have shown is that clinical judgment only takes you so far. You really do need these models and algorithms to help you treat patients. They're not onerous, they're not overly time-consuming. I think there's a fear that, oh my God, how am I going to do this? It's going to take so much time, and I don't have that time. And I agree, actually, we don't have that time. I don't have that time. But just like everything else in medicine, you could learn a skill. It's a new skill to learn, which I think we're all capable of doing, and translate that into routine practice. It does not add a lot of time. As a matter of fact, in most of these studies, it's been shown that it only takes a few minutes, and very often the patients actually assess themselves. And it's really up to you just to interpret the information that they give to you. Very simple issues like, can they take care of themselves? How do they function in society? Do they live alone? Have they fallen? I mean, very kind of rudimentary, simple things, but have been shown to be highly predictive of outcomes, not just survival, but drug toxicity. There's very little data on drug evaluation in older patients, and this has been a big problem. And because of that, we really have to be very cautious about extrapolating data that's derived from large clinical trials of younger patients to older patients. And fortunately, through these researchers, we have the tools to at least start to do that in a meaningful, data-driven fashion. I think we owe it to the older patients to do these kind of things, to avoid undertreatment, to avoid overtreatment, to avoid toxicity, to maintain quality of life and maintain independence. And one of the great things about the SIOG organization is we bring together people from all over the world who have various experiences about investigating older patients, taking care of them, this cross-cultural fertilization that we have, because in our current meeting there are people from 42 countries, I believe. And this is an extraordinary, valuable experience to help clinicians take care of their patients. And I think this has been very fruitful, and I'm hopeful will continue to expand because the older patient population is expanding. In terms of geriatric oncology, I think what's happening is, well, the new drug development. There's been a lot of focus recently on immunotherapy, precision medicine, genomic analysis, and this is something that could be extrapolated to older patients. Better supportive care issues are always important. The use of radiation therapy in a limited but precise and effective fashion. For instance, fewer fractions. I mean, patients will not have to come to the clinic as often. I think this is an area of investigation. So I think these are exciting times in certain diseases, and I think there's a shift away from, not totally, but there's a subtle shift away from conventional chemotherapy, and we really have to learn how to use these new drugs in older patients, how to design clinical trials which are applicable to older patients, because we have to get out of the mold where we've been doing it really for decades with standard chemotherapy, and how to use these new drugs and evaluate them in an appropriate manner for older patients. And I think that's what's, in the next year or so, I think there's going to be a tremendous focus on not just the new drugs themselves, but how to evaluate older patients in that context.